Hello and welcome to our podcast in which we explore the profession of mental health care providers in Ghana. I'm Naomi Roberts.
My name is Corey Schmolka.
My name is Molly Herring. Today we'll be talking about our experiences investigating mental health during this last chapter of TBB. We were able to visit health centers, CHPS centers, which stands for Community-Based Health Planning and Services, a prayer camp, and the regional hospital to talk with employees and explore different methods of treatment for mental illness.
So, Molly, what inspired you to study mental health for this country's media project?
Well, I did some work with some mental health organizations back home, and I was curious about what the system looks like in Ghana. What about you guys?
I think I came into Ghana with some assumptions about what the country's mental health care system would look like based off of any number of things, and so I wanted to challenge those assumptions and dig deeper.
Just a little intro into what mental health looks like in Ghana. Here is Faustine, a mental health nurse at a CHPS center in Taviefe, talking about what her responsibility is in her community and some common mental illnesses she sees in her office.
So our main job is to identify psychiatric conditions. As they come, we'll do home visits. Through home visits, active case search, then we'll identify the conditions as they come. Those with mental illness, the psychosis, we have the schizophrenia, the delirium, the acute phases, and all those things.
Mental health in Ghana was drastically improved with the Mental Health Act of 2012. However, there are still only 3 psychiatric hospitals in the nation, 2 in Accra and 1 in Cape Coast. There are less than 15 psychiatrists in the country. The funding that is supposed to come from the National Health Insurance Scheme, which amounts to only 0.4 to 1% of the allotted budget, is not always reliable. So, when clients can't pay and the government refuses to, where does the money come from? Here's Faustine.
It's supposed to be free. The client don't need to pay for it. But because of the funds that are not coming from the government and the medications that are not coming, the patients have to buy it themselves or pay for any services that is rendered. If we have the medications, we give to them. But if you don't have them, meaning they will be there like that, they will not take the medications. You see, the client is not having money. At times, I'll give it to them. When they get the money, they'll come and pay, or at times, I just buy it and give to them.
We talked to Lomasi, another mental health nurse, at the Kpetoe Health Clinic. When we asked Lomasi where money comes from if not from the government, money for food, water, medication, and other means of supporting her patients, this was her response.
It comes from the nurse's pocket. We also pay for transportation when we are going out to the communities. We are going out to the communities for DEVAs, outreaches, health talks. We pay. There's nothing. I don't have any means of transporting myself to these villages, so with my other colleagues, we all go through the cries of no medications for clients. We are all crying for funds for community work. And we are all crying that mental health is not where we are expecting it to be.
It is so incredible to hear how Lomasi has, without second thought, taken it upon herself to fill in the resource void from the government. Patients can't afford medications? Lomasi will step in. Patients have empty stomachs? Lomasi will feed them so they can take their meds. Patients don't make the effort to come to the clinic? Lomasi will pay for her own taxi to go to their communities to check in. How can nurses be expected to make so much personal sacrifice? Is it sustainable? Lomasi said it herself. Mental health in Ghana is not treated as it should be.
We were able to learn a lot about how mental health is treated when it's done properly and how mental health care funding from the Ghanaian government under the National Health Insurance Scheme functions. However, the scheme is far from perfect. Here is Lomasi talking about her attempts to help support her uninsured patients by appealing to the government.
We are supposed to be covered under the insurance and it's supposed to be free. But last year, for instance, I compiled a list of names of clients who are non-insured, and in collaboration with the social welfare, when we submitted our letter, we were declined.
Lomasi was my favorite person to interview. She had so many surprising stories to share. Being the only mental health nurse at Kpetoe Clinic, her office was very secluded around the corner. She told us that some of the general nurses and other staff at the clinic don't even know her unit exists.
Not only do mental health professionals lack recognition, funding, and medicines, but they also lack the infrastructure necessary to ensure their safety. Lomasi told us about the struggles of being alone in her one-room unit. Here she is talking about her experiences with aggressive patients.
As a single person and a woman, as a matter of fact, how am I going to be able to restrain probably a well-built gentleman who is aggressive? We are always in danger. We are understaffed as mental health professionals. I'm just the only one. I fear for my life because unfortunately there is no form of insurance. If I should get hurt, I would have to foot every bill by myself. And it became the most hard when I had to be bringing my boy in, and then I have an aggressive patient coming towards me. He starts crying at the back. So I tend to have a divided attention because I want to figure out how I'm going to calm him down, and I'm also trying to figure out how I'm going to calm my clients down.
After talking to Lomasi, we figured it might be interesting to hear the perspective of another kind of mental health care professional in Ghana. We made our way to the psychiatric ward of the Volta Regional Hospital to have a conversation with one of the mental health in charges, Mac.
Mac echoed some of the safety concerns that Lomasi felt. He told a story about the dangers of home visits that really stood out to me. This is his advice.
Don't be surprised. Going to visit is very dangerous too. Sometimes a client will pretend to be nice. Oh, come in. You will come in and he will lock the door, or she will lock the door and go get, a machete.
I think it is really interesting hearing that from a male in the profession, and also from someone who gets a lot more support working at a hospital as opposed to a health or CHPS center. For example, he told us there is a social welfare office at the hospital that will provide NHIS cards to any mental health patient for free. The facility is very well equipped to take care of patients that are at a financial disadvantage. He attributes this to the amount of pressure the mental health unit at the hospital puts on the Human Resources Department.
And we report to management and they take charge. Yes, so they provide clothing in connection with social welfare. Clothing, food, they're being fed, they give medication, they take medication free from the pharmacy store with no charges. And they provide bed, yes, a roof over their head, while social welfare go to the community to locate family members. Because as the HR, we worry him a lot, and he tends to, listen to our needs, in administration. For this hospital, they do a lot, in that regard. They help us, they listen to us. For our requests, when you put it in there, because we tend to give them a lot of pressure.
Even though the hospital is much more prepared for patients that can't pay, there are some things that are out of their control. Medicine can go out of stock nationally and nothing can be done about it.
Sometimes it could take a year. We wouldn't have no drugs to be given to clients for free. Yes, sometimes our pharmacy stocks certain medication under the National Health Insurance Scheme, but it's not that much. Maybe just for anti-seizure medications, then certain tranquilizers like diazepam.
We learned that hospitals and clinics are not the only treatment centers for mental health patients in Ghana. Prayer centers are quite common given the large role religion and spirituality play in the lives of Ghanaians. Mac recognizes how patients typically seek out religious treatment, and rather than fight them on their beliefs, the hospital has formed a partnership with the local prayer center. Here is Mac explaining how closely they work together.
Yeah, but they refer them, okay, your medication is done. Have you gone for review? If no, please do. Or they call us to come there, assess, do the vital signs, the most important things, check sugar, blood sugar, and all that. They will give the medication repeatedly.
We learned a bit about prayer camps during a public health seminar on mental health. Prayer camps have a history of human rights violations. It is not uncommon for a family who attributes mental illness to curses or evil spirits to leave a patient out of prayer camp indefinitely to receive treatment. Treatment can be anything from prayer meetings to exorcisms to chaining patients to a bed and forcing them to fast. Nowadays, there are regulations to ensure prayer camps are not committing human rights violations. They are much more focused on moving mental health care from institutions to the community in order to teach patients how to maximize functionality in their lives.
Corey and I were fortunate enough to have the opportunity to visit a prayer camp ourselves, namely the El Batel prayer camp of the Pentecostal Church in Ho. We spoke with the leader and head pastor of El Batel, Elder Pesa, about the camp's mission, commitment to human rights, and relationship with the Volta Regional Hospital. The conversation was, as one might expect, pretty religiously charged, but above all else, the pastor seemed to have a genuine commitment to ethical practice and a passion for helping those in his community who need it. Here's what he had to say about the importance of maintaining human rights in the camp.
The Mental Health Authority goes around the whole country to see, because when you go to some places, they chain the mentally challenged people, which is against human rights. Because of that, the government has made a policy to go around all places that is known as prayer centers and see how they are handling. Among all the prayer centers in the nation, we stand tall. Yeah, knowledge is power. So we have decided not to be so crude, but to be very, very open to international standards.
As a prayer center, there are, of course, religious undertones of every aspect of patient care and treatment. The pastor shared with us how strongly he believes in prayer's efficacy. His conviction was so easily heard in his tone and seen in his body language and hand gestures.
For the past 5 years, by the grace of God, about 8 people who were dead and declared by doctors on the way to be buried, prayed for them, and they have all come back to life. That is how we have become so certain about the preaching of the gospel. Raise the dead, cleanse the lepers.
Before visiting the facility, we wrote out some questions for the pastor. We thought the answers might be fairly conservative, but didn't really know what to expect. Here's the pastor talking about what he considers questionable practices in America.
How can a woman marry a woman? Is it normal? How can a human being marry a dog? Is it not bestiality? Is it not mental derailment? Think of it logically. How were you born? Just simple questions. But the devil has taken over the minds of people to the extent that they are no longer thinking as logical people.
Though Pesa never says outright that he considers homosexuality to be a mental illness, he says some things that we were a little uncomfortable with. He groups homosexuality with bestiality, and in the form of a rhetorical question, categorizes both as a mental derangement. After this, we found ourselves questioning some of the practice of the prayer camp and wondering what is considered a mental illness within its walls.
One thing is definitely clear to me. There is a stigma around mental illness. We learned in our public health seminar about some of the misconceptions behind those stigmas. For example, people think it's contagious, something you can catch. People think that by working in the field of mental health, you put your kids at risk of mental illness. It discourages staff from specializing in mental health. And beyond that, those who do specialize in it often are stigmatized by their own colleagues. Both Lomasi and Faustine told us about some of the stigmas that they themselves are the victims of.
We found ourselves as a mental health trainees being addressed as, I'm going to say it in the local dialect, abodam nurses, which simply means mad nurses.
And at times you end up with Nikki's names like that, abodam. You yourself here, you are sick. At times you do something happens and people say, oh, no wonder you are doing mental health.
We are stigmatized even as mental health care providers, even within the health sector.
It is a shame to see mental health professionals stigmatized when everyone that we interviewed told us they need more professionals, more resources, and more attention. All 4 were very passionate about their jobs and were able to convey feelings of hope and pride, not only in their patients, but in the mental health system's potential for improvement. Mac and Faustine emphasized that recovery depends on the effort of the health staff to check up on the patients, meet them in their homes, and provide lots of love and support.
That's primary care and primary love. That's what the community persons are there for. Yeah, show love at home and at the workplace. And they tend to recover more faster. The health person has come to visit me. That is encouraging. Yes, that means there's love even at home and at the workplace or where I go to clinic.
Most rewarding if you see a client that they are improving. You are treating them, they are on medications, they are taking they are taking their medications on time, they report on time, and you see improvement. things that they are not able to do now, they are doing. They maintain their personal hygiene and all those things.
Reflecting on our interviews and experiences visiting these different facilities in Ghana, it seems like the biggest holes in the nation's mental health care system are a result of a lack of understanding and awareness about what exactly mental illness is. How can the mentally ill be treated if what it means to be mentally ill isn't entirely understood? It isn't as if the system is all wrong. The professionals we spoke with have faced struggles, sure, but they've also triumphed and succeeded in helping so many individuals, employing their compassion and desire to do good all the way. Still, there is so much room for improvement.
I think it's easy for me to approach this topic with a standard for how I think mental health should be, based off of what I know about treatment in the US. I think you're absolutely right, Naomi, that there is room for improvement, and I think that's true for the treatment and understanding of mental health all over the world. The best way to find out what successful mental health care looks like is to give a voice to those that work in all of the different types of systems and experience successes and failures on a day-to-day basis. It's also important to remember that mental health care is not and will never be one size fits all.
Our podcast hardly even skims the surface of mental health care in Ghana, but this is only the beginning of my exploration. Now that my interest has certainly been sparked, I hope to continue having these awesome conversations and learning from dedicated and passionate professionals. And I hope you learned something from our podcast. We definitely learned a lot in the making of it. Thanks for listening.